Good joke when they all come in. So, yes. Yes, 1, 2, 3 laugh. And then we'll, no. Okay. Not her. She's okay. The rest of them, though. You can do it for him. Anyway, okay, so let's do our review. So unfortunately, I can't do a Kahoot because it is the questions are too long in a lot of cases, and so it's not really great. There'll be some explanation slides on here as well, but we'll kind of talk as we go through it. And then these should be somewhat representative of stuff you're going to see on the test. Again, a lot of definitions, a lot of kind of interpreting. You know, hey, we have a study that does this. What's the best test to look at? You know, if we covered that, what's kind of study design is this? You know, little things like that. So it's going to be pretty similar to the first test. It's just kind of shifting the focus more onto the epidemiology side of things. Okay, so any questions before I get started? Nothing at all. Okay, so reviewing. So if you remember, what's the difference between incidence and prevalence? Anyone can describe it? Yeah, so incidence is going to be new cases going forward. However, prevalence is what? All the existing cases at a specific point. That's that point prevalence we talked about, right? And again, it's good to be able to differentiate between those two incidents. Or new cases. Now, what would it be if, say, I was looking at, say, something that could happen multiple times? I was looking at the incidence over that period of time. We call that. We look at the density of the incidence. Incidence density, right? So again, I could look at something like, you know, patients who are getting recurrent UTIs or something like recurrent pneumonias or something. I can count how, you know, say 3 people, I'm following them for various numbers of months and they have different numbers of attacks. I can kind of come up and see what the incidence density is, and then I can then extrapolate that out to say like a wider population. Okay, so again, kind of have an idea of those different concepts behind different types of prevalence and incidence here. Now again, you know, we were looking at like this graph here. This is telling us about new cases of HIV that was being diagnosed. The white bars would be these incident cases, right? Or I'm sorry, the entire height of the bar was the incident cases here. The white ones portions are going to be the patients who are still alive at the end of it, right? So if I were to tally up everyone who had the disease at the end of the study period, what would I call that? So either have it or they don't at the end of the study period. I call that prevalence, right? So at that point, it's just looking at the prevalence there versus if I'm looking, say, forward in time, looking at the new cases that pop up, I call that incidence. Okay, it's a little bit different there. Okay, so review questions. The beings model was a useful paradigm for what? Yes, sir.
You said adding up all the white bars gives you the prevalence?
That would be the prevalence at the end of the study, right? Because again, those are the people that were still alive at that point. So the beings model is a useful paradigm. Did it help us with allocating public health resources? Was it useful for assessing the impact of herd immunity? Was it good for determining the role of social policy on public health, establishing the importance of social contacts, or evaluating etiological factors in disease? Remember the beings model. It's from one of the first epidemiology sections there. It tells going to be a lot of me talking to myself, so it's okay. Wait, actually, what it is though, that's what it is, right? In this case, and everyone sees the slides are actually I posted those, so you can kind of go through it. You can look ahead and you can make yourself sound really smart because you already know all the answers, right? Right. So this are those etiological factors here, right? So for instance, we're looking at the N was like nutrition, right? So you can see like, okay, well, diets high in saturated fat. What kind of effects would they have on things like cardiovascular disease, right? You have things like B being behavior, or people smoking, or are they having premarital sex, or are they doing whatever the case may be. So again, those are different factors that kind of fit into things you want to look at to see how they're affecting the occurrence of the disease that occurs secondary to those different aspects there, right? And again, I'm not going to go over these entire slides. You know, we kind of talked about it. So, all right, this is the number of new cases over a defined study period divided by the mid-period population at risk. You call that. Remember, whenever you use the mid-period population in your denominator, what does that turn into? Changes from a risk into a turns into a rate, if you remember, right? Because remember rates in the different types of, the different nursing homes where people all died at either the very beginning, or they kind of died kind of throughout the year, or they died at the very end. We call this the incidence rate, right? You want to see the incidence of something occurring, whether it be death or whatever the outcome you're looking at. If you were just to take the entire population, so you have 100 nursing home residents, and I say you have a 10% risk of death over the year, and I say, okay, well, the risk is 10 over 100. It's 10%, right? If I use that mid-period population, though, that's when it turns into a rate, and so that changes the denominator. Okay, risk only uses the full population. Rate's going to use that mid-period population. Okay, so this is the observed total deaths in a population divided by the expected deaths in that population multiplied by 100. What was this? It's going to be the standardized mortality ratio, right? So this is giving us an idea, being able to compare what we'd expect the number of deaths to be in a particular, say, group or say in a particular time frame, whatever the case may be, and then actually taking the number that we see, dividing by that observed, right? And so that will give us an idea: is death occurring less frequently? Is it happening more frequently? Again, it's looking at the observed versus the expected. Okay, so it'll give us an idea. And again, why do we multiply it by 100? Because it gets rid of the fraction, right? So instead of saying like, we had 0.83 deaths, as our mortality ratio, by multiplying by 100, you could just say, hey, it's 83%, or whatever the case may be. So that kind of helps people work better when they have whole numbers to work with rather than dealing with decimals and all that, right? This is the proportion of individuals with a given condition who die of that condition. Right, so remember we talked about you can be exposed to something, but you don't necessarily get the disease. You can have the disease, but you don't necessarily manifest symptoms. You have symptoms, but you don't necessarily die from it, right? Remember all those subsets of populations that fit when you're looking at patients who are, say, having a given exposure. If you're looking at the proportion of people who have the condition and that die from that, what do you call that? Again, definitions are good to know for this. This is going to be the case fatality ratio, right? So if you're looking at the number of people who died, who got influenza this year, you consider that the case fatality ratio, right? So the number of people who have the disease is the denominator. The people who died are going to be your numerator there, and that gives you that ratio. And then you can compare that from year to year or do whatever you want with that, right? This is the number of live births divided by the mid-period population. We're talking about neonatal mortality and looking at different factors on how it affects the mom versus the baby. When you look at the different types of death or birth rates, this is considered a crude birth rate. What do you think crude birth rate tells us? Kind of just like the overall, health of the population. Obviously if they're having more babies, they're probably more healthy. That kind of makes sense there. Now, the question is this a valid rate, right? So again, if I take the entire population of the U.S. and I'm looking at the number of births that we have to get that crude birth rate, is that a valid rate? If I take the whole U.S. population, can every single person in the U.S. population have a baby? Absolutely not, right? So again, it's not considered to be a true valid rate, but it's still something that they do pretty commonly when you're comparing things like, crude birth rates between nations and things like that. Knowing if something is a valid rate or not is also good to know. So for instance, if you're looking at, say the incidence of, cervical cancer, make sure it's only going to be in people who are actually at risk for it, right? Female patients, all of that. Those are good things to kind of key in on, right? Whether rates are going to be valid or not. This provides the death rate in a defined age range. Right, this was good when we were talking about the death rates compared between different countries and how if you just look at the crude death rate overall, it can be kind of misleading, right? Because you can have some countries who are skew a little bit younger. Younger people typically die less than older people, and then you can compare that to say to other nations where they have maybe skewing a little bit older. So that was the case we were looking at things like Ecuador versus say Switzerland, right? Switzerland tend to skew a little bit older, but by looking at the actual age range, it's called the age-specific death rate. You can then kind of break down patients into their specific groups, say older than 50, say 20 to 50, and then less than 20, and then get a little bit better apples to apples kind of comparison there, right? Because again, the nation that skews younger, they're going to have a higher proportion of those people in the younger age groups. You can see that their death rates are going to be lower anyway, right? Okay. Okay, so let's get into sort of a scenario here. Let's say we have a politician is throwing a luncheon fundraiser, trying to get some money for his bid for re-election coming up, and they have various types of seafood. Excuse me. I was about to sneeze. Oh wow! I actually never sneezed during class. It's very odd. I haven't really thought about that before. Still going strong, right? All right. Anywho. Okay, so let's say they have this fundraising luncheon, and they have the salmon mousse that they're providing there, and then within 24 hours, they had 11 of the 17 diners were experiencing abdominal pain, they had vomiting, and they had diarrhea, okay? Of this 11 symptomatic patients, 4 had fever, and then 7 did not, okay, out of that group. 5 had an elevated white count, 6 did not. 6 of them ate the shrimp bisque, 5 did not, and then 9 of them ate the salmon mousse, 2 did not. And they had one guy who ended up going and having surgery for acute cholecystitis. Do you think that's related? Probably not, right? But again, you want to kind of include that information there, right? So again, he's still considered to be symptomatic, but he wasn't really fitting the bill there, okay? Most of the patients ended up recovering within 3 days or so. Obviously, the guy went for surgery, had a little bit longer recovery period here, right? So we're going to have some questions regarding the kind of the details here, right? So one of the first things we're going to figure out is, is this an outbreak or not, right? What do you consider an outbreak to be? What's that definition? Something occurring more often than what the normal baseline is, right? So had I sneezed right there, that would be considered an outbreak of sneezes by my part because I don't sneeze during class. That is the normal is 0. So even one case of it, of a sneeze, would be considered abnormal, right? Not probably the best example, but it's an example. Okay, so let's ask, the phenomenon described here, is it a coincidence until proven otherwise? It's a disease outbreak. It's attributable to bacterial infection. It is not an outbreak because the usual pattern of disease is unknown, or it should be investigated by the CDC. What do you think? This to be a disease outbreak, okay? Now again, just because you don't know what the normal pattern of disease is, if you have 17 people having dinner or having a luncheon and then 11 of them develop abdominal pain, diarrhea, vomiting afterwards, is that considered probably normal? No, unless you're maybe eating at the wrong places. But typically that would be considered abnormal. So you can certainly say, yes, this is probably an outbreak in this case here. Now, again, could you say it's a coincidence until proven otherwise? 11 out of the 17, that many people having the same in moose? Probably not a coincidence, right? So again, at least it will lead you to think, let's investigate this a little bit further. Now, why can't I say that it's a bacterial infection? Why can't I attribute it to the bacterial infection? I just don't know yet, right? So again, I don't have enough information to make that diagnosis or not. So I can't say whether it's viral, bacterial, it could be anything, right? So you don't want to kind of prematurely ascribe certain causes to it. And then should it be investigated by the CDC? Probably not, right? When does the CDC get involved? Just like interstate sort of things, or a particularly really serious sort of thing. If this came out and it turned out it was anthrax causing this abdominal pain, all this stuff, would that be grounds for the CDC to get involved? Probably, right? If anthrax case, because that is biological warfare weapon, that would be something they probably want to get involved in. But unless, usually it kind of starts with a local sort of state health department, and then sometimes they can kind of kick it up to the CDC if they want some additional help here. Probably not in the case here. Probably just normal food poisoning. So looking at this, the attack rate would be what? Would it be 4 out of 11, 5 out of 11, 11 out of 13, 1 out of 17, or 11 out of 17? What do we consider the attack rate to be? Basically the number of people who are affected over the total number of people who are at risk, okay? So in this case here, we could say, well, until we kind of know what the offending agent is, we can say, okay, well, everyone at that dinner was at risk, but 11 of them developed symptoms, so you could say 11 out of 17, right? Now, if you could then get more honed down to say, well, just the people who had the salmon moose, then that attack rate would change, right? Any better, we're going to go ahead and just kind of go cast the widest net at this point, okay? Now, in early priority here, when we're trying to investigating this phenomenon here, we would say, should we close the kitchen temporarily? Should we define what a case is? Should we perform a case control study, perform stool tests, or then submit food samples to the laboratory? What do we think? First thing you always want to do is try to define what it's going to be, right? So you need to identify who am I actually going to be including that needs to be kind of further investigated, right? So if I had those 6 other people who had no symptoms whatsoever, do I want to include them in the investigation? No, they're asymptomatic, right? I can kind of automatically discard them, but I need to come up with a case to determine who should I discard, who should I keep around for that investigation there, right? You can close the kitchen, but I don't even know if that was to do with that, right? Maybe it had something to do with, say, a mysterious package they all received, and all of a sudden there's a white powder in it. Who knows? Is it time to perform a case control study? Probably not at this point, right? Maybe later on if it was found to be more of a kind of a widespread sort of thing. How do you design a case control study? How would I divvy up patients? It's good to know these, kind of how these studies are broken out. So the case control study, I start out with my case. People actually had the outcome of question, right? And then I can match them with who? People who did not have the outcome, right? So if I want to do a case control study, I could take people who developed the abdominal pain, the nausea, vomiting, diarrhea, and I can compare them with people who are very similar to them, who did not have any of those symptoms, and those would be my controls, right? Then I look backwards in time to see what were the risk factors. To say, oh, all these people ate the salmon moose. Obviously, this is a much higher likelihood that this is the causative agent here, right? Now, if I want to do a cohort study, how would I design that? Remember, with cohort studies, you want to start out with the risk factor, right? With case control studies, you're starting with the outcome and looking back to see what the risk of having that risk factor was. With the cohort studies, you're starting off with the people, either they had the salmon moose or they didn't have the salmon moose, and then you look forward to see whether or not they had the abdominal pain, nausea, vomiting, etc. Okay, so again, knowing the different study types is good to know as well, right? So that we can kind of identify what are they doing, what are they actually looking for, etc. Okay. All right. Let's say the best case definition for the guest in this point would be what? Would it be someone who has abdominal pain, vomiting, diarrhea within 24 hours of the state luncheon? Would it be acute viral gastroenteritis? Would it be staphylococcal food poisoning, the onset of abdominal pain and fever after the state luncheon, or vomiting, diarrhea, and elevated white count? What do we think? And again, when you're doing this case definition, you want to get the things that were common to all the people who were affected at this point. And the definition can change over time, but did most of the people end up having a high white count? No, only a couple of them did, so I can't say that. Do I want to include people who had fever? No, because not a lot of them didn't have fever associated with it, right? Only a few of them did. So again, by using just abdominal pain, vomiting, and diarrhea within 24 hours, that gives me a good temporal time frame, gives me the things that were common to the people who were actually affected there, right? Now, why couldn't I say viral gastroenteritis or staphylococcal food poisoning? I have no idea what it is at that point, right? It could be viral, could be staphylococcal. We just can't say at this point, not enough information. Now, let's see, suspecting that the disease is a result of a common source exposure, right? Remember, there's common source exposure where they had exposure just to one thing at one time versus more of those propagated sort of exposures. Maybe there's like contaminated water line or something like that they keep going back to. Let's say it's just a common source exposure. We want to kind of determine what food is responsible. So the first thing we want to do is we want to analyze food specimens in the laboratory for everything that was eaten there, close the kitchen, examine the food preparers. Do you want to interview symptomatic guests to find out what they ate or perform a case control study? Close the kitchen? Let's close it down. Instead, we got all these people coming in for dinner later on. Too bad. Yeah. Start with the easy things. Let's do the easy things first, all right? Let's interview the people who got sick to say, well, we can't send everything of food out there for testing. Maybe we can figure out they all ate the same thing. Then, yeah, send that out maybe. Maybe you can close the kitchen, but I think in this case here, just starting with the simple thing, just talking to people, just getting the history can be most useful at this point, right? Okay, next, a screening program analog to the late look bias would be what? Would it be length bias because cases lasting longer are more apt to be detected, recall bias because only severe cases are recalled, selection bias because the program selects out asymptomatic illness, selection bias because the program only selects out for severe cases, or spectrum bias because the cases are clustered at one end of the disease spectrum. So the question is, the late look bias, what is that in the first place? Okay. And this is that phenomenon where basically if you're looking at disease over time, especially if you're looking sort of at the end of a study period, people who either got better or died, they're not there to be looked at anymore, right? So again, it's one of those things where we may miss people because they kind of recovered or they died or whatever the case may be. They're not there to really measure anymore. You're kind of looking more not only at the cases that were kind of long-lasting or more indolent. That's what we call the late look bias. So when you're doing a screening program, something would be kind of analogous. Basically this length bias, because basically the cases that are lasting longer are more likely to be picked up versus the ones that are very quick, rapid, and done and over with, right? So again, knowing the different types of bias can be very useful for testing purposes, but also when you're looking at these surveillance programs, like what are the limitations here? What kind of bias are they introducing based off of whatever their methodology is going to be? Something like, selection bias is where you may be selecting out for certain individuals and not including everyone who may be at risk for something. So that would be, a little bit different here. Spectrum bias is going to be more where if you're only looking at certain patients who kind of fit one particular spectrum of disease and maybe some of the other ones may have less severe illness, maybe didn't get included for whatever reason. Right, so again, the late look bias is very similar to the length bias, basically. All right, let's say this is one of my favorite questions to ask. For whatever reason people like it, but let's say we have a study we're conducting. We were looking at the effects of drinking Mountain Dew on a teenager's willingness to bungee jump from frightful heights. Okay, so let's say we take our patients here. We have our teenagers. We have a total of 500 teenagers who were assembled on the basis of their bungee jumping status. Okay, so we had 250 jumpers and 250 who were not jumpers. Okay, of the 250 jumpers, we asked them. We looked back and they said, okay, well, 150 of them reported drinking Mountain Dew. They say, yes, I did the do. And then of the 250 non-jumpers, they look back and they saw 50 of those drank Mountain Dew. Most of the non-jumpers also report a preference for warm milk, preferably from a bottle. Okay, so which of the following statements would you consider true in this case here? Jumpers and non-jumpers should be matched for their beverage consumption. The absolute and relative risk of bungee jumping can be determined from this study. This is a cohort study. This study can be used to calculate an odds ratio, or unanticipated outcomes can be assessed in this study here. So the question, what type of study is this even in the first place? Anyone know? It's case control? Why do you think that? Because the next slide says so? Perhaps. Let's look at it. So basically, this is what we're considering, what are we categorizing patients on, right? What categories do we divvy them up into? Whether they jumped or they didn't jump. Okay, jumping was the outcome we're actually looking at, whether or not they actually went bungee jumping or not. Then we're looking backwards to see what? Whether they drank Mountain Dew, right? So again, that's the risk factor. We're looking to see patients who have this risk factor, are they more likely to be a jumper or a non-jumper, right? Or the people who did jump, are they more likely to have drank Mountain Dew, right? It's kind of the thing they're looking at when you're doing this case control study. So you take the jumpers, you're using the controls of the people who didn't jump, and then looking backwards to see whether or not they drank that Mountain Dew. Okay, so this would not be a cohort study. Now, if I wanted to make a cohort study, how would I design that? Yeah, I did 250 people. I did force feed Mountain Dew, preferably the whole 2 liter. 250 people I did not give any Mountain Dew to, and then I look forward in time to see did they bungee jump or not. Okay, so that's kind of the difference there. Are you starting out with the risk factor or the exposure, or are you starting out with the outcome? Okay, case control, you're starting out with the outcome. Cohort studies, you're starting out with the risk factor. Okay, good. So looking at that, when you're using a case control study like this and you're looking backwards in time, why would we not want to match them based on beverage consumption? So that way you're only comparing people who drink Mountain Dew jumpers with non-jumpers who drink Mountain Dew. Because that's what I'm actually curious about. I actually want to see were those people who were jumpers, were they more likely to drink Mountain Dew? So if I were to match based off of that, then I eliminate that effect. And so I can't really determine anything. That's what we call that overmatching, where you make the people look too similar to one another. And when you go back, they all have the same risk factors, so you can't really make any conclusions there. So in this case, I do not want to match based off the beverage consumption. That's the thing I'm actually interested in, right? That's what was my hypothesis. So the other big thing to know is what type of statistical tests can you do when you're actually doing these type of studies. And one thing I will tell you is that when you're looking retrospectively and you're doing a case control study, you cannot do absolute changes in risk. You can only do relative estimations of this, right? So that's why you see a lot of odds ratios being done for these case control studies. Okay, so in this one here, it said the absolute and relative risk of bungee jumping can be determined. That's not the case. You cannot do an absolute difference because again, we don't know basically what that whole pot of people we would actually be pulling from is. Versus if I did a cohort study where I said, okay, here's 250, here's 250. I have my whole population right there. I already know what my denominator is. When I do a case control study, you don't know what the denominator is, and so all you can do is say, okay, well, these people jump. These people did not jump, or these people drank Mountain Dew, these people did not drink Mountain Dew. And so you have to use an odds ratio. So that's just one of the things you just need to know, that case control studies use odds ratios. They cannot get absolute changes in risk. Okay? That makes sense? Because again, with the case control studies, we're looking at the risk of having the risk factor, essentially. That's kind of what you're looking at in those cases there. Okay? And then with this one, unanticipated outcomes can be assessed in the study. That's not the case because, again, I'm starting out with the outcome already. I'm only looking backwards to see what the risk factors were. I can't look at new outcomes. If I was doing a cohort study, I could look forward in time and then look to see what other outcomes actually happened there, right? Okay, so we kind of get a good feel for the differences between a case control and cohort study. All right, so the odds ratio calculated from this study would give the odds of drinking among jumpers to drinking among non-jumpers, drinking among non-jumpers to drinking among jumpers. It's only a little bit confusing, but drinking Mountain Dew just to jumping in general, jumping among drinkers to drinking among jumpers, or non-jumping among drinkers to non-drinking among jumpers. What's the actual comparison we're looking at, right? And so we kind of already said it, right? We said we're looking at what is the people who are jumpers versus non-jumpers, what was the risk of them being Mountain Dew drinkers, okay? So in this case here, is drinking among the jumpers versus drinking among the non-jumpers. These are my cases. These are my controls I'm comparing them to, right? And so I'm looking to see what is the risk of them actually having that risk factor. And I can develop an odds ratios from that. And it'll say, yes, people who drank Mountain, people who are bungee jumpers, they were 3 times more likely to have drank Mountain Dew than non-jumpers, right? So maybe I'll do like a safety campaign saying like, hey, don't drink so much Mountain Dew, otherwise you'll have spontaneous cases of bungee jumping or something like that, right? Whatever the case may be. Or maybe if I was a Mountain Dew executive, I'd be more likely to market around bungee jumping stuff. I don't know, who knows? But that's basically the comparison you want to make there is the drinking among the jumpers versus drinking among the non-jumpers. All right. And the results of the study would indicate, let's say we had a positive odds ratio. We would say that bungee jumping and beverage choices are associated. We'd say bungee jumping and beverage choice are causally related. Bungee jumping influences a person's choice of beverage. Choice of beverage influences a person's tendency to bungee jump, or there's no association between warm milk and bungee jumping. What do we say? We can basically say that the bungee jumping and beverage choice are associated. So why can't I say there's a causal link? It's a case control study. It does not tell us cause and effect, right? We can look for associations, but we cannot look for true cause and effect. Now, what would be the gold standard to show a causal relationship? Randomized control trial. Randomize teenagers to either drink Mountain Dew or not drink Mountain Dew, and then I look to see how many of them went to go bungee jumping afterwards, right? So that would be the best way to look for a causal relationship. Here, we're just looking for an association, right? Now, let's see. Bungee jumping influences a person's choice of beverage. You can't say that. All you can really say is that people who were jumpers were more likely to drink Mountain Dew versus those who were non-jumpers were less likely to drink Mountain Dew, right? So you can't really say that one's causing the other in those cases. We don't know if there's a temporal relationship. Right, so that's a kind of big thing to take away from that. Kind of understand what you're actually looking for when you're getting these odds ratios and whatnot, right? So we say there's an association, but not a causal relationship. So if I can't find cause and effect, what's the benefit of doing a case control study versus just organizing a randomized control trial? It's really easy, right? It's easy and cheap, and oftentimes it can help you with like designing hypotheses for future studies potentially, right? So again, when you see these studies and you're like, man, this is like a really kind of rinky-dink sort of study, like who in the world even designed this? Oftentimes it's like college projects and stuff like that, like PhD students who are designing this stuff. They're just looking retrospectively. Oftentimes it's a lot easier to get a study done that way than trying to organize something that's expensive and time-consuming and whatnot, right? That when they went to the New England Journal of Medicine, well, the top journals that are out there are like, 28,000 patients followed for 5 years on median. Like that's an incredible amount of work versus just doing a quick retrospective case control study. Easy, right? Comparatively speaking. So let's say we were to randomly assign subjects to either 2 years of PA school. This is our intervention. This is actually the experimental side of things. Or they just had 2 years of just regular graduate school. And this would be our control. And then we are looking for evidence of mental health afterwards. Okay. So of the 100 subjects assigned to each condition, we find evidence of mental health in only 12 of the PA school students versus 92 in the control group. Would you say this is accurate, anecdotally speaking? You guys all have mental health? Just mental health in general, just so you have health. I mean, we know we have issues, right? That's understandable. But let's just say they have evidence of good mental health in only 12 of those students versus, say, 92 in the control group. So approximately, an appropriate measure... I actually bumped a little too hard. Anyway, an appropriate measure of association in the study is, we look at incident density, power, likelihood ratio, odds ratio, or risk ratio.
There's no way to stop. There's no way to stop. Just let it go.
I had to let it go. I just can't. Just like Elsa, I'll let it go. So the question, what's an appropriate measure of association in the study here? So again, how did I design the studies, right? So was this prospective, retrospective? What do you think? It's prospective, right? Because again, I organize people to either go to PA school or regular graduate school, right? And then what did I do? So that was the risk factor, that was the exposure, what type of school they went to, and then I look for the outcome of whether or not they have evidence of mental health, right? Good mental health, I should say. So what can I look for here? Should I look at an odds ratio, a risk ratio, a likelihood ratio? Well, do is a risk ratio, right? So basically, by looking forward in time, I can look at the risk of developing mental health or having good mental health versus the risk of not having it for these patients here, right? So that's why oftentimes when you're looking more retrospectively, like in those case control studies, you're using odds ratios because, again, I don't know what the full population is. But in this case here, with this prospective study, I have 100 in each group. I know that my denominator is 100, right? So that's why I can use things like risk ratios. I can also use absolute risk changes, right? So I can look for absolute differences between the two. I can subtract one from another, not just using ratios overall. Okay. What would I use incidence density for? Since I mentioned it a while ago. It's going to be something that happens like multiple times. I'm kind of following different patients for different periods of time, and I kind of add up all the incidents together. And so I say, hey, you did 11 cases per 30 people years, you know, of acute otitis media, whatever the case may be, right? So that would not be the case here, right? Let's say we want to determine the proportion of myocardial infarctions that are fatal within 24 hours of their occurrence. You decide to examine records of all local emergency departments and physicians' offices. You'll then calculate the proportion of the reported MIs that resulted in death 24 hours or less after the patient was initially seen. You briefly discuss this with your local friend, the biostatistician. You know, this is fictitious because no biostatistician has friends, but he says you actually have a problem here. You have a bias that's been introduced in this type of study. What type of bias is it? Is it a late look bias? Is it a lead time bias, measurement bias, observer bias, or selection bias? So good to know the different types of bias and how it's going to be affecting the study potentially. So clearly determine that you have a late look bias. What was that late look bias? Well, does every single patient who has an MI show up at the physician's office or at the ER? What happens to some of them? They die at home, right? So they may never actually get included in that. So you could have this thing where these cases that were very quick, very rapid, and deteriorated very quickly, they may be underreported. And so that's what we call that late look bias. You're only getting those cases that were kind of more longer lasting. They actually made it to the hospital, et cetera, in those cases there, right? So that's the big thing to note with that one. It's called late look bias or a Niemann bias. You may see called that as well. You know, some of the other errors, you know, if we had something like an observer bias, what do you think that could be? It's usually who's ever taking the data, right? Someone to say they misclassify someone and say, oh, you know, that was chest pain, but I think it's probably due to pneumonia. We're not going to include them as having MI, right? And that was a misdiagnosis or something. That could be like an observer bias. Lead time bias is going to be more for something that kind of takes a while to kind of build up to it. So you may, if you kind of measure them too early, you may actually miss those cases there. But again, get a good feel for the different types of bias that are out there. Let's say you should know this based off of your microbiology class recently, but the mosquito involved in transmission of malaria assumes a role of what? Animal, reservoir, parasite, surrogate host, vector. That everyone should know. One's pretty easy, right? Like the host, vector, all of that. You know if you have a change in, say, for instance, host defense, how that changes things a little bit. You know, so kind of get a good feel for that kind of that life cycle there. Which of the following would best describe the effect of vaccination against diphtheria when the disease was more common than it is currently? So right now, diphtheria is not very common. Let's say back in the day when vaccines are starting to come out, but diphtheria was much more prevalent in the population. What, you know, which of the following could kind of best describe that situation there? We could say that frequent exposure resulted in boosted immunity after immunization. You could say frequent exposure resulted in an infection against which the vaccination was not protective. We could say susceptibility to severe infection redeveloped several years after vaccination. Say vaccination resulted in hypersensitivity to the infectious agent, or vaccination resulted in unusually severe clinical cases when immunity was not achieved. So again, people are getting vaccinated, but the disease is still pretty prevalent. Well, is that frequent re-exposure oftentimes boosted the immune system, right? So nowadays, when you don't have very much exposure to things like diphtheria, what do you need? You have to get a booster every once in a while, right? Because we don't get re-exposed to it. We don't have re-exposure to diphtheria. And so what happens to that immune response after a period of time? It gets weaker over time, right? That's why we look for things like titers and for things like, you know, hepatitis B and whatnot. We want to make sure you still have a good immunity against it. And so that because we are healthier as a society now, where this disease is not very common, we don't get really challenged by it. And so in those cases there, you find that that's one of the kind of the negative effects of vaccinations. We kind of lose that natural booster effect, but we just get around it by changing our dosing schedule and reapplying the vaccine as needed. See, data reported for cases of relatively mild diseases, so say for instance chickenpox, can usually be characterized as highly accurate because of active surveillance. Is it useful for establishing prevalence but not incidence? Is it valuable for detecting changes in the pattern of disease? Is it valueless because mild diseases are underreported, or valueless because most patients with mild disease do not present for medical care? What do you think? For mild disease, you typically find that the value of the reporting is generally going to be that you're looking for trends over time, right? So again, does every single case of chickenpox get reported up to the health department? Probably not. So again, it's pretty mild. People may not even go for medical care. You're going to find there's a lot of underreporting. So it's not really good for getting things like the incidence down to a T for prevalence and whatnot. However, you're going to find that by getting kind of the general trends, if you were to see an upswing, all of a sudden more people are showing up and getting sent to the hospital, et cetera. That is good to know, right? So you can see those changes there that happen. Now, is it highly accurate because of active surveillance? What is active surveillance? We talked about that, and basically that's where someone's actually actively looking for these cases. They're calling up the hospital. They're saying, "Hey, have you had any cases of chickenpox lately?" You know, they're actually sending out surveys or whatever the case may be. This is much more of a passive sort of thing, where as the cases come in, you may see it, like, hey, maybe I'll report it, but it's not going to be one of those things that's actively monitored for. And usually, you're going to find that's more underreporting with passive surveillance, right? Let's say we have the following deaths are reported for a population. We have 2,807 men. They're all aged between 35 and 68. We have 4 deaths in patients who are non-smokers during this study period. We have 11 deaths in men who are smoking 1/2 pack of cigarettes a day. We have 18 in men who are smoking 1/2 to 1 pack cigarettes per day, and then 43 deaths in men who are smoking more than 1 pack per day. From this data right here, just what you have right here, what can you conclude? One, that smoking increases mortality. The relationship between mortality rates and smoking is linear. The dose-response relationship between smoking and death, or there is a dose-response relationship. To interpret the data, age at the death is required for each case. And then to interpret the data, the information must be expressed as rates for each risk group. What do we think? What we can say is that to interpret that data, we need information to be expressed as rates. And how do I turn a risk into a rate? The mid-period population, right? So again, for that study period, I need to be able to figure out what that force of mortality is. Because just because I had 11 deaths in men smoking 1/2 pack of cigarettes a day, does that mean it was from lung cancer or because of the cigarettes? I can't make that assumption. It could have been hit by 11 buses, right? Like who could say? So because of that, I can't say necessarily that there's a causal relationship here that says that smoking increases mortality. There could be something else going on. There could be some other effect modifiers playing a role here, right? Until you have more data, you need more information to say whether or not the relationship is linear. You can't say necessarily there's a dose-response relationship. We do see an association there based off of that, but we need more information to get more cause and effect sort of analysis. Okay. Which of the following examples might represent a retrospective cohort study? So we talked about cohort studies a lot of times being prospective. Which one may be retrospective? Would it be cases of lung cancer assessed for prior exposures? So we start out with people who have lung cancer and then look for prior exposures. Subjects randomly assigned to active varicella vaccine versus placebo, followed by chickenpox, followed for chickenpox. Subjects with current angina followed for the development of MI. Subjects with prior radiation exposure followed for the development of lymphoproliferative cancers, or subjects with skin cancer assessed for lifelong cumulative sun exposure. So what do we think? I think it's C. Actually D. So let's look at what a retrospective cohort is, right? When we say cohort study, what are we divvying up the patients based on? Their exposure to a risk factor, right? So we're not starting out with the outcome. We're starting out with the risk factor. So in this case, with something like lung cancer, starting with lung cancer as the outcome, we can't look backwards. That's going to be what we call a case control study, right? So that would not be the case here. How about subjects randomly assigned to active varicella versus placebo followed for chickenpox? That's a randomized trial, right? It's a prospective randomized trial. That would not be the case there. In something like subjects with current angina followed for the development of myocardial infarction, that's a prospective cohort study, right? Because again, they have current angina, and we're following them for the development of MI. However, with this one here, D, we're starting with patients who had prior radiation exposure, so in the past, and then we look kind of forward in time, not looking in the future. We're looking forward in time to see if they developed any of these cancers there. So that's what we call a retrospective cohort study in those cases there. So for instance, like when I did my research in fellowship, we did a retrospective cohort study because I was looking for patients who got bit by coral snakes, what type of treatment strategy they got. So I divvied up patients based on they got early antivenom or late antivenom and then followed them to see what their outcomes were. It was never prospective. I never looked in the future. I only or look forward in time. I only ever look backwards, right? So kind of get a good feel for that retrospective versus prospective cohort studies. Okay. The Physician's Health Study was a randomized, double-blind, placebo-controlled trial that was designed to test the effects of aspirin and beta-carotene for CV disease and cancer. Participants in the trial had 22,000 male physicians who lived in the U.S. They were 40 to 75 years of age. Randomization in the study was performed to achieve which of the following? Does it eliminate bias? Does it have external validity, internal validity, prevention of confounding by known and unknown factors, or statistical significance? Why do we randomize patients? This is to help with the removal of the confounding, right? We want to make sure that the groups are very similar to one another. Otherwise, you may be able to attribute some of the outcomes based on differences in the baselines of those patient groups, right? Now, when I say internal validity, anyone know what that means? It means about the actual methodology of the actual the study itself to make sure that internally it makes sense based off the type of analyses that I'm doing. The study methods make sense. How about external validity? What does that mean? Well, can I take this information and then apply it out to the larger population? Now, why was this one may have limited external validity? It's not very generalizable because who are the subjects? Older male physicians, right? So again, it's going to be something where it's not super applicable to any females, people with lower socioeconomic status, people who are younger. So again, it's not very generalizable. It has a pretty poor external validity there. It does not eliminate all bias. It may help with some bias, but really the big thing is trying to get rid of those confounding variables there, just at the baseline demographics. And then let's say we have a new disease being reported in the U.S. It's called maple syrupitis, originating from Canada. Let's say it's been reported to have caused 5 deaths so far, and your hospital starts to initiate screening for all patients reporting to the ER, and they to see whether or not they've traveled to Canada in the past 6 weeks. What type of surveillance is this? Is it passive or active? It's active because, again, the nurses are asking every single patient who comes in. This is very similar to when we had like Ebola that was starting to pop up. We were asking, have you traveled to Sierra Leone recently, or what was the other place? I had it the other day, but I can't think of another country. Anyway, there's a set of countries. Good thing we had it on the list so we could ask them, because otherwise they forget too. But yeah, so this would be a case of active surveillance, because you're asking every single patient. So that way, when you find it, you're much more likely to actually find it if you just had never asked a question to begin with. And then what phenomenon might you call those first few deaths that occur there? Call that the iceberg phenomenon, right? Because that's one of those things where oftentimes you kind of get those high-profile cases that are first, kind of the more severe cases you hear about first. There's probably a lot more people that actually have the disease than what you're just hearing about in the news, and so it's kind of the tip of the iceberg, we like to say. So a lot more people probably have the disease, but now we have an increased sort of surveillance for it, where we're going to be able to find those people a little bit easier, because we're going to be able to ask, have you been to Canada recently? That's not a real disease, just so you know. Okay, so that's it for the review. Any questions? Congratulations, you finished your last lecture for your fall semester. You only have a whole nother didactic semester to go. That's probably worse than this, but yay. All right. Please make sure you turn in the journal club assignment, so that way everyone gets credit for that. And then make sure you feedback on the reviews. Have you guys already done your evaluations? Please. Oh, if you haven't done it yet, please give good constructive feedback. It doesn't have to be good, but just constructive feedback is very useful. Thank you.